Hello and welcome to the March 2023 LACNETS educational event. I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on updates in NET clinical trials with Dr. Heloisa Soares. A special thanks to Ipsen, Advanced Accelerator Applications, ITM Pharmaceuticals, Lantheus, and Crinetics for supporting our LACNETS patient education programs. LACNETS stands for Learn, Advocate, Connect, a neuroendocrine tumor society. Our name also states the mission of our patient advocacy organization. While you often see Heather and I leading meetings and programs, we are in fact led by a team that includes Executive Director Kavya Vellakabuti, who has been serving as a LACNETS board member since 2015. Our board also includes Donna Gavin, who is also the sister of LACNETS founder Giovanna Joyce Mbesi, and NET patient Mary Dunleavy, who has been living and thriving with NET for over 18 years. I'm now going to hand it over to Heather to share some important tips about today's program.
Thank you, Lisa. Our YouTube channel features over 280 videos. Use our playlist to find webinars on imaging, PRRT, nutrition, liver-directed therapy, PhioPara, our annual conferences, guided meditations, and patient stories. Follow LACNETS on social media to stay up to date on our upcoming webinars and NET news. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And be sure to add us to your safe sender email list. I'd like to remind the audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in the webinar are the expert's personal opinion. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back to Lisa.
Thank you, Heather. I'm pleased to introduce today's speaker, Dr. Heloisa Soares, a NET medical oncologist from Huntsman Cancer Institute, University of Utah. Dr. Soares received her medical degree in Brazil, where she was born. She completed her residency training at Mount Sinai Medical Center in Florida and her hematology oncology fellowship training and PhD in molecular biology at UCLA. Neuroendocrine tumors and gastrointestinal cancers are the major focus of her research and clinical activities. She serves as the medical director for the Clinical Trials Office, as well as a co-physician leader in the GI Clinical Trials Research Group at Huntsman Cancer Institute. She is a member of the NCI NET Task Force and member of SWOG and NRG cooperative groups. This really means that she's very busy and active in clinical trials. Dr. Soares is also a leader in the NET medical community, and she serves on the board of directors for the North American Neuroendocrine Tumor Society, or NANETS. She is also a panel member for the Neuroendocrine and Adrenal Tumors NCCN Clinical Practice Guidelines in Oncology, which serves as a resource for clinical practice guidelines. Dr. Soares is not only a dedicated clinician and passionate researcher, as you've already heard, she practices what she preaches. This fight to find new and better treatments for NETs is also personal to Dr. Soares because her brother is also living with NET. Dr. Soares truly understands the value of community and how it takes all of us to move the field forward. Welcome, Dr. Soares.
Hello, everyone. My name is Heloisa Soares. I am a neuroendocrine cancer expert and medical oncologist here at the Huntsman Cancer Institute at the University of Utah in Salt Lake City in the US. And I'm very happy to be here with you discussing one of my passions, which is clinical trials, particularly for patients with neuroendocrine cancer. Thank you so much for the LACNETS to give me the opportunity to share some of the exciting trials and progress that are going on right now. So with no further ado, let's talk about updates in NET clinical trials. So in terms of disclosures, I just want to mention that I did receive some consulting advisory board honorarium for a few companies. They're all within the conflict of interest policy from my institution. Also, I should mention that as a job description, I am a clinical trialist. So part of my career is to develop and conduct clinical trials. I'm also the medical director for the clinical trials office here at Huntsman. So obviously very invested in advancing the field of cancer through clinical research. So before we dive into the NET clinical trials, let's just try to understand a little bit what are clinical trials. I understand that many of you in the audience might be very savvy on the topic, but for some of you might be a new concept or information. So what are clinical trials? These are studies that are developed to find new ways to prevent, detect, control, or treat a disease like cancer. The goal is to find a new treatment is safe and effective in treating the disease of interest here. And it's important to include all types of people in clinical trials because different patients and subjects might respond differently. So in order to have a well-balanced trial, we should make sure that we have diversity of age, race, gender, ethnicity. What are some of the misconceptions about clinical trials? Well, that only people that are ill can participate. That's not true. There are several clinical trials that are developed and conducted in normal, healthy folks. All the trials have a placebo arm or a sugar pill. That's not true either. Many trials do not have a placebo arm. The clinical trials are for those who don't have any options left. Also not true. Many times we can offer a clinical trial as the first option of treatment for patients. And you are going to see some examples that we are going to discuss later on today. So you can consider a clinical trial in any place of your journey with a neuroendocrine cancer. And the clinical trials are very costly to patients. That's also not true. Typically, any cost that's associated to any extra steps or exams or tests from the clinical trials are going to be covered by the clinical trial. And things that are considered routine and what's called standard of care might be charged to your insurance, but that's not a true extra cost in terms of performing procedures of the clinical trials. Also, depending on the category of the clinical trial that you choose to participate, if you live far away from the center that you are receiving your care through a clinical trial, there might be opportunities to receive reimbursement for hotels, gas, and even food. So always ask about that and look at what your informed consent says about it. What are some of the facts about clinical trials? That both healthy and patients with medical conditions can participate. Many times in these trials, patients receive the standard of care in addition to experimental drug or treatment, and that is never too early to participate, as I mentioned before. So what are the stages of a clinical trial? Most of the time before drug is tested in humans, it has to be tested in preclinical settings, looking in the cell lines or sometimes in animals, most of the time in mice, sometimes depending on the drug and what is required in other animals, such as monkeys as well. Then once the compound passed this preclinical phase that shows that there is some signs that the particular drug might work in the group of diseases, then this drug is tested for safety, and that's called a phase 1 study, whereas typically a small amount of patients, the number of patients in which the drug is tested, and the dose of the drug that is tested, it gets escalated and increases to understand what is the maximal dose that is tolerated by patients. Some of these phase 1 trials can be what's so-called first in human, where the participants are indeed the first ones that are receiving the drug. But sometimes some of these phase 1 trials is actually a combination of drugs, such as a drug that is already approved, and then you add an extra drug. And we wanted to see with a phase 1 trial that the combination of these both drugs is also safe. Once we determine what's this safe dose of the drug to give to patients, then we move to an expansion of safety and also to look at efficacy of drugs, which is called phase 1, 2, or phase 2. the number of patients in that proportion of trials tends to be a little bit bigger. And once we see that there is a signal of activity in terms of safety, the drug tends to move to what's called phase 3, which typically when the drug is compared against standard of care. And normally we need several hundred of patients to have a drug into phase 3, sometimes even thousands depending on your hypothesis. So how long it takes to have a drug developed, right? We always say, oh, this drug is so promising, but it takes too long. We're doing better in terms of moving the pipeline. But here you can see that can take more than 10 years or 12 years to get to the point of having a compound or a drug that works in the mice or in cell lines to move to get approved in our country by the FDA, for example. So out of about 5,000 compounds that are screened, maybe just one might actually make it to the market. So just to give you a sense of how complex and intense is this process to get there. What are the benefits of being a participant in a clinical trial? Well, taking aside the potential that you actually benefit from the drug per se, you also have many members of the care team taking care of you while you are in the trial. You have much more intense access to doctors, nurses, research coordinators, and pharmacists. I joke with my patients that we watch you like a bulldog. And also, there is the benefit of groundbreaking scientific advances. They're only possible because someone accepted to participate in a clinical trial. And here are some of the examples. Trastuzumab is a drug that we use on a particular subtype of breast cancer that used to be devastating. And thanks to the development of this drug, the natural history of HER2 breast cancer changed completely in 1998. Another drug that really changed the natural history of a disease, which is called chronic myelogenous leukemia, or CML, is the imatinib. They really changed. Patients before used to have to get transplants and their survival was very limited. Once this pill was developed, it was like a game changer. And now there is second generations of the same sort of class of medications. Immunotherapy also was a game changer. When I was a fellow, all my patients with melanoma, which is a skin cancer that's very malignant, used to pass away very quickly from the disease if the disease has spread. And while I was in fellowship, immunotherapy starts to develop, and we were seeing the benefits in patients already participating in clinical trials. And now, even though melanoma is a terrible disease if it has spread, we have so much more that we can offer to patients, and the life of the patients can be much longer, thankfully, for the development of immunotherapy drugs. Everolimus, in the case of neuroendocrine tumors, it was approved some time ago and was another drug that really improved the progression-free survival, how long the tumors take to grow again once you are in the drug. And what we all know is about PRRT, right? We all know how wonderful it is to see the progress that we made for the treatment of neuroendocrine tumors, thankfully, to use an approval of PRRT with lutetium-177 in the United States, which was a game changer in terms of how long the patients can have stable disease or even some response before the tumors starts to grow again. It's more than 2 years of stability of disease in at least half of the patients that receive PRRT. And we were only able to get the approval in the United States for this drug because of clinical trials that were done. So why is it important to be aware of clinical trials? Because we need to change the perception of what is a clinical trial. People think, oh, I just don't want to be a guinea pig. And it's not true, right? There is research that shows that about 85% of patients don't really understand or are unaware of the participation in clinical trials can be an option for them. And 75% of these patients said actually if they were aware of a clinical trial, they would consider enrolling and participating in the clinical trial. So as a community, we need to make everyone more aware of these options. So this is just to give an example of the development of NET treatments in terms of the pipeline. We see that in the 1980s, we had octreotide and some chemotherapy with streptozotine and 5-FU for pancreatic neuroendocrine tumors. Then in the 90s, we had the lanreotide development, which is a somatostatin analog. And then we can see a few other developments, such as sunitinib and everolimus, when the results become available in 2011 and led to the approval by the FDA. And a few more here. And you can see that now we're in a such busier area. Not every single drug gets approval in the United States or Europe, for example, and we'll give some examples, but just to give you a sense of how much we have moved the field forward. So Dr. Coombs, who you probably all know and love, because she's a great teacher and NET specialist, she recently showed in January of this year during our big GI oncologist American meeting some of the recent results. So she had developed and conducted, along with colleagues, the study that looked into capecitabine and temozolomide versus temozolomide alone in patients with well-differentiated, locally advanced or metastatic neuroendocrine tumors of the pancreas. And thanks to this study and the patients' participations, they were able to show that patients that receive capecitabine and temozolomide in pancreas neuroendocrine tumors that are well-differentiated have a much longer progression-free survival in terms of median. What does that mean? That at least half of the patients that receive the combination drug live without having the tumor grow for more than 22.7 months. And patients that only use temozolomide, the time that took for the tumors to grow in half of the patients was about 14.4 months. They also show that perhaps if you have what's called MGMT deficiency that you can check on the tumors, there is a higher association to response rate. Overall, this response rate of the tumors in these patients was about 40%. And what does that mean? That how much the tumors shrink. And to be considered a partial response, the tumors have to have a shrinkage of more than 30% or more. So sometimes we see the tumor shrinking a little bit, but your doctor might come back to you and say, oh, by what's called RECIST criteria, that's a way that we formally assess how much the tumor shrink, you didn't achieve more than 30% of shrinkage. So you have a stable disease. But if your tumors, when they calculate it, they pick up, they choose some of the tumors that we see in the scans, they have some calculations, and if after the calculations your overall burden of disease shrink more than 30%, then you have what's called a partial response. If someone has a complete response, that means that your tumors cannot even be detected anymore. And boy, it feels good to tell a patient that either they had a complete response or they have a partial response. In the end of the day, the most important is to prolong survival, but it certainly feels good to also see some shrinkage, especially if the tumors are causing a lot of symptoms in patients, and shrinking the tumor might improve symptoms such as pain or abdominal discomfort. The side effects of the combination treatment that were reported were fatigue, nausea, vomiting, diarrhea, issues with the blood counts, and irritations in the hands and the soles that they might feel red and blistery. None of the side effects were unexpected or new to this combination of drugs. Other recent results that Dr. Coombs mentioned during her presentation was about trying to understand sequencing strategies for patients with well-differentiated neuroendocrine tumors. Why? Because we know that typically for the first-line treatment, if someone systemic needs to be given, we use somatostatin analogs. But after that, there's a list of drugs that can be used, and we really don't know what's the best sequencing to use, right? Should we do drug A versus drug B, or should we do drug B versus drug A? Does it change the overall progression-free survival or survival of patients? So in this study, they look at streptozomide and 5-FU followed by everolimus, or everolimus followed by the chemotherapy. And they showed that the chemotherapy combination had a little bit of a higher response rate, but it was similar in terms of how long it took for the tumors to progress. Another study that was done was to look into, for patients that have pancreatic neuroendocrine tumors, for which sunitinib is approved, which is an oral pill, doing PRRT with lutetium-177 versus sunitinib which one will give the initial higher and longer progression-free survival. Again, how long it takes for the tumors to start to grow again or for new tumors to appear. The study showed that PRRT was better in terms of a longer progression-free survival, which was good because that's typically how we always thought in our heads, but it's also good to have that validation. And then there was an exciting phase 1 trial looking into alpha emitter, which is felt to be more potent and potentially even safer for patients that receive PRRT. And they had very exciting results, and they showed that in the first 10 patients that received this alpha emitter, the response rates were about 80%, which is very nice, because if you are aware of the NETA-1 data, which is the PRT study that was comparing versus a higher dose of somatostatin analogs, the response rate was about 18%. And I should mention that for this phase 1 study, this is a population that had received PRT before with lutetium and now was retreated with this alpha emitter with lead. Another study that we were really looking forward to potentially considering adding to our menu of FDA-approved medications was a pill called surufatinib. There was a novel agent targeting some of the tyrosine kinases related to how the blood vessels rearrange and a few more things. So it's a TKI. And was very encouraged. It had very encouraging results in phase 1 and phase 2 studies in NETs. And then 2 big studies were conducted in China, looking into surufatinib versus placebo, both in pancreatic versus non-pancreatic neuroendocrine tumor patients. And in both studies, actually, the drug was better than placebo. So the company asked for the FDA to approve that medication here in the US, but unfortunately, after evaluating the data, the FDA felt, and the European organization as well, that we needed more data outside of China to make sure that this positive effect of the drug was true in other populations. Going back to the fact of diversity that I mentioned before, it's always important to test a drug in different populations to make sure that everybody has the same response. Then in terms of cancers that are a little bit more aggressive, such as the grade 3 neuroendocrine neoplasms or the poorly differentiated neuroendocrine carcinomas, there was a recent study that looked into second-line treatments using liposomal irinotecan and 5-FU versus docetaxel. And actually, we were able to show that liposomal irinotecan and 5-FU had a little bit of a longer progression-free survival in terms of 6 months. Another study that was done was to look whether or not bevacizumab, which is an anti-EGF drug, which again helps to reshape the blood vessels around the tumor, adding to FOLFIRI will be beneficial in this more aggressive population. And unfortunately, the results show that there was no difference in overall survival. Finally, the results of this ECOG 2142 trial that was led by Dr. Jennifer Eads from the University of Pennsylvania and the ECOG cooperative group showed that capecitabine and temozolomide was not superior to platinum etoposide as the first-line treatment for patients that have high-grade neuroendocrine neoplasms like the G3s. And now the question is this because the poorly differentiated G3s are very different from the well-differentiated G3s. And that needs to be determined, so hopefully additional studies will be done in the future. So now let's talk about the exciting ongoing clinical trials that we have. For a long time, there was not a lot of first-line trials because we have octreotide, which the commercial name is sandostatin, and lanreotide, which the commercial name is somatostatin, as the first-line treatment for neuroendocrine tumors if the decision was to use a somatostatin analog. Well, that's changing. Right now, we have this oral somatostatin analog that is being tested in this randomized fashion to look at the safety of this oral somatostatin analog called paltusotine in patients that have carcinoid syndrome. And this is a study led by Dr. Aman Chauhan. And you look here at the eligibility criteria of the trials. And I haven't, up to now, I really haven't talked a lot about eligibility criteria. So what is eligibility criteria? So when you want to participate in a trial, there are certain checklists that you have to make sure that you fit. And in terms of inclusion eligibility criteria, you have to make sure that you do have what is described there. For example, you have to have documented carcinoid syndrome requiring medical treatment. You can be naive of receiving a somatostatin analog but symptomatic, or you can have received lanreotide or octreotide or short-acting and your symptoms are controlled. You have to have disease that are measurable on scans. So if you have carcinoid syndrome, but when you do your imaging studies, either with MRIs or CT scans, and we cannot really clearly measure the tumors with a ruler, then you're not eligible for the trial, and that's not a trial that you'll be able to qualify for. You cannot have progression of disease in the last 6 months for this trial. So if your doctor tells you that unfortunately your scans show that you have progression of disease, then you know that trial is not for you. What are some of the exclusion criteria? Things that if you have, you are not able to participate. So if you have diarrhea for any other cause that's not carcinoid syndrome, the trial is not for you and you won't be able to participate. If you have uncontrolled diarrhea causing this significant issues such as dehydration or hypotension, this is not a trial for you. If you have received PRRT in the last few weeks, that trial is not for you because you don't fit that eligibility criteria. So as much as you might want to participate in a clinical trial, you have to pay attention and discuss with your care team that and ask the question, do I qualify for the trial? And then in terms of this study, one of the main things that they wanted to assess initially is the incidence of side effects related to the drug. But obviously they're collecting many additional points, such as does your diarrhea improve? Does your 5-HIA decrease with the use of these medications and so forth? So this trial is open in few countries, and I believe in Kentucky and maybe a few other places in the United States. And if you are interested in this trial, you can go to the link that you see in the bottom, clinicaltrials.gov, and type the number, and you will be able to see in the bottom of the web page all the sites or cancer centers that have the trial open. Typically, they also have an email to communicate with a person of that particular trial. Let's say if the trial was open here at Huntsman, my email will show up and you could send me an email and say, hey, I think I qualify for this trial. What do you think? And then probably I'll say, well, tell me a little bit about you. Let's make an appointment and then we'll go from there. Another thing that you can bring that information to your local care provider and say, hey, do you think I qualify for this? Can you help me to get into this trial? Do you know anyone that has the trial open, and so forth? This is a lot of team effort and communication with your care team to see which trials do you qualify and make sense for you. Another trial looking at somatostatin analogs and this CAM 2029, which is a randomized trial looking into studying this drug, which is the CAM 2029, which is a octreotide subcutaneous instead of intramuscular, compared to sandostatin or lanreotide in patients that have GI neuroendocrine tumors. They want to compare the efficacy and safety of this new formulation, which they believe has potentially more power and is subcutaneous and is given every 2 weeks. And after the initial phase of learning about the injection and how to do it, patients can actually self-inject, which I think is a very good option for patients, so they don't have to come to the centers to get the injection. So what is the eligibility criteria for this trial? Patients have to have confirmed well-differentiated tumors with the GI tract or presumed to be GI tract, and confirmed histological means that you have to have a biopsy, you have to have tissue. Just imaging is not enough. Once again, you have to have disease that you can detect on scans, and your disease has to be positive on the imaging scans that show that you have expression of somatostatin analogs. In the old days, used to be octreoscan, Most of you probably do not get ocular scans anymore because we have better imaging studies, which the commercial names are the TechNet and NetSpot, or we say DOTA-TATE PET-CT scans. And you have to be fairly fit with a performance status between 0 to 2. That's another thing that we haven't touched yet. What is a performance status? Is how fit the patients are. Someone that has a performance status of 0 has no symptoms whatsoever from the cancer. Someone who has a performance status of 1 has some symptoms but is still very functional. Someone that has a performance status of 2 is a little bit less healthy, if I may, but is able to do all the usual activities of daily living. Someone that has a performance status of 3 is someone very ill that probably spends a lot of most of the time in bed or in a couch and has no ability to do many of their independent things, such as going to take a shower by yourself. Most of the trials are not going to allow patients that have a performance status of 3 to be participating on the trial. So if your loved one are very, very debilitated, chances are your loved one is not going to be able to enroll on a clinical trial. Just to give you a sense of what is a performance status. Sometimes we receive calls of patients that are in bed and really very debilitated, and that's not someone that will quote unquote qualify for a clinical trial. As sad as it sounds, we just know that these patients in general tend not to do well, and then they will introduce another variable to the trials and perhaps not give the drug the opportunity to show that works because the patients are already very debilitated. In terms of eligibility exclusion criteria for this particular trial, carcinoid syndrome is refractory for any of the traditional treatments is an issue. So if you have uncontrolled diarrhea, this trial is not going to be a fit for you or your loved one. And this is a global trial, meaning that several countries are represented, and hopefully we'll have a lot of diversity in the population. Hopefully that's an efficacious treatment. Patients that were selected by randomization, which is, I say like is a flip of a coin, is the computer decides which treatment you're going to get. If they are randomized to the standard of care, at some point later they can be considered to switch into the experimental drug, which is the CAM 2029 in this case here. And in the bottom is the number that you can identify the trial on clinicaltrials.gov, where you can look and see if there is any centers close to you that have this trial. So let's switch gears for PRRT, or peptide receptor radionuclide therapy. And I know that you're looking for this part. So right now we're talking about two different timings of PRRT. The first time that you receive PRRT, I call it the first round. And just for those who are not aware, typically the complete treatment of PRRT is 4 cycles every 8 weeks in between cycles. So to have a complete treatment, normally you do four cycles. Eventually, a patient might not tolerate to complete 4 cycles unless it's done sometimes 2, sometimes 3. Issues with the blood counts can be a barrier to completing treatments or to having to delay the treatments because your blood counts, meaning your white count or your platelets, might not have recovered from the prior round of treatments. So what we have for trials that look into PRRT, we have the CompareNet trial, that's an alliance trial that look into doing PRRT with lutetium-177 or chemotherapy with capecitabine and temozolomide in patients with well-differentiated pancreatic neuroendocrine tumors that are advanced or metastatic. And why this trial is important is because, as I mentioned before, we have several options to treat patients, and we don't have a good sense of once patients progress or if patients have a lot of disease to begin with, what is the best course of action. In this case, particularly in pancreatic neuroendocrine tumors, where we know that capecitabine and temozolomide is very efficacious, thanks to the work from Dr. Coombs and colleagues from ECOG. We don't know, right? Because CAP10, we saw that might have a 40% response rate. And we don't know in a control setting up to recently, what is the response rate and progression-free survival of patients that receive PRRT for pancreatic NET. If you remember, the study that led to the approval of PRRT in the United States was done in small bowel midgut tumors, and that was extrapolated to all GI tumors, thankfully to many studies that have been done in a non-controlled fashion in Europe. So putting all that together, that led to the FDA to feel comfortable approving PRRT for all the GI well-differentiated GET-NABs. But we don't really know a lot of the response rates specifically on PNETs and PRRT. So that's a study that's going to look into that. This is also a study that if patients have a lot of disease to begin with and need a rapid response, they don't have to wait to have the disease grow after using a somatostatin analog. They can be considered right away. And there is few other eligibility criteria. So please, if your care team discussed this trial with you, consider participating, because actually my answer a very important question, because we always struggle to decide what's the best option for patients. And obviously, without good solid data, is a discussion with the patient, and obviously the patient has a say as well. I'm particularly invested in this trial. I'm the co-study chair, and Dr. Hopday from Mayo Clinic is the study chair. And this is a trial that's part of the National Clinical Trials Network, which is sponsored by the NCI. And I want to give a shout out to the NCI because they are really doing a lot to move the field forward, and they are extremely supportive of neuroendocrine tumors. So shout out to the NCI and the National Clinical Trials Network, along with the corporative groups that are part of that. Another study that I think is super important and we need to focus in finding patients to participate is this randomized phase 2 trial looking to lutetium-177 or Lutathera versus everolimus for patients with neuroendocrine tumors of the lung that are positive tumors somatostatin receptor imaging, such as the dotatate PET-CTs that I mentioned. And this is important because I touched on this before. The FDA label approval is only for GI origin neuroendocrine tumors or unknown origin that you feel is GI. And there is no FDA label approval for the using lung nets. So some patients that have lung nets might find challenging to receive the treatment because the insurances might decline approval and say there's no data. So this is a trial that is going to help us to answer that question. Is PRRT with lutetium-177 a good option for patients with lung nets? This is a study that has been developed by Dr. Tom Hope and colleagues from UCSF and is supported by Alliances. Again, is an NCI-sponsored trial. Kudos again to the NCI. And patients that have positive somatostatin receptor tumors in the imaging with the dotatate scan and had progression of disease in the last 12 months can be randomized to the PRRT versus everolimus if they have not received everolimus in the past. If they had already received everolimus, then they are not eligible for this study. And patients that, in the flip of the coin, I say that's the randomization, they were randomized to everolimus at the time that we see progression, assuming that they continue to do well in terms of their performance status, blood counts, and so forth, they will be given the opportunity to switch to receive Lutathera. This is a treatment in which the Lutathera or lutetium is actually sponsored by the NCI, so insurances are not charged by that. And the goal of this study is to see improvement in progression-free survival, or meaning how long it takes for the tumors to start grow again, and for us to see new lesions. Then we have the COMPOSE trial, which is lutetium-177 with a different somatostatin peptide called odotriotide versus standard of care that your physician decides for you for neuroendocrine tumors that are well differentiated but a little bit more aggressive. They have a Ki-67 of more than 15, if my memory is correct, and patients that have a grade 3 tumors. The tumors have to be positive on the somatostatin receptor imaging with dotatate, and they can be of GI or pancreas origin. And then patients will be randomized to either receive up to 6 cycles of this PRRT versus one of the systemic treatments that your physician will decide for you. And that can be capecitabine and temozolomide, can be a combination of drugs called Fulfox or everolimus. Also a very important trial, and if you feel you fit the eligibility criteria, please discuss with your care team. And again, in the bottom, you can find more information at the clinicaltrials.gov identifier. If you type the number on Google, it will lead you to additional information from the trial. Another trial that was recently shown as a trial in progress, and this trial is actually India. The team from LACNETS made me aware that this is an international audience. So I wanted to mention some of the studies that have been done elsewhere, not only in the United States. And this is a study to look into lutetium-77 Lutathera plus or minus addition of chemotherapy if patients have disease that is positive not only on the somatostatin receptor imaging or the FDG positive imaging as well, which looks at the sugar uptake of sugar in the cells and tell you that these tumors may be a little bit more aggressive. So for this particular trial, you can have grade 2 or a grade 3 tumor, but your lesions have to be positive in both the dotatate PET scan and the FDG PET scan. Again, if you are in India or you were recommended PRT, consider discussing this possibility with your care team. Now, one of the trials that I know everybody is also very excited about is the AlphaMedix 02, which is a multi-center phase 2 trial looking at lead-212, which is alpha emitter, which we believe that has strong power to treat the cells because it can penetrate somewhat in a very powerful way, but doesn't go to normal tissue that much. So perhaps could be more potent and less toxic. And the initial study looking into the safety and adverse effects related to this trial showed that was very promising. So now they moved to a phase 2 for patients that haven't been treated yet. The safety study was done in patients that were retreated with PRRT, but for this particular study, this is the first time, or PRRT naive patients, and they can receive this treatment. So patients have to have unresectable or metastatic biopsy proven neuroendocrine tumors. They have to have progression of disease. They have to have had progression after receiving the somatostatin analog injection. We do need to make sure that all the lesions that we see on the CT scans are also seen in the dotatate PET CT scans. You have to have acceptable performance status up to 2 and acceptable blood work. And here, just for reference, because I'm sure this is going to be a popular study that you guys want to look, meaning that your total white count has to be above 2,500, that your neutrophil count needs to be above 1,000, platelets have to be above 1,000, hemoglobin has to be 9. So if your hemoglobin is 7, it's probably not a good trial for you. Your liver enzymes have to be acceptable. Your albumin level has to be 3, and your kidney function has also to be acceptable. If you have received any PRRT in the past, you're not eligible for this study. And also, if you have a history of blood cancers, such as myeloid dysplastic syndrome, unfortunately, you're not eligible for this trial. And patients will receive 4 treatments of this alpha particle with lead 121. Now let's talk about retreatment. That's another hot topic. So we can use PRT for the first treatment of patients after they progress on somatostatin analogs or the first round. But now more and more we're seeing data to tell us that it's safe and perhaps efficacious to retreat patients with PRT. And there's a lot of retrospective data from Europe and Australia that reinforces that. So many studies looking at retreatment are being conducted. One of the studies that's going to be open hopefully in the next 3 months is actually sponsored by the National Clinical Trials Network and the NCI. Again, kudos to them. and is going to look at retreating patients that receive up to 3 to 4 doses of lutetium-177, and then if they did not have progression for at least 12 months, at the time of progression, they would then be randomized. Again, you don't choose, the computer chooses for you which arm do you get. They will be randomized to another 2 treatments of PRRT with lutetium or everolimus. But at the time of progression, if you were on the standard arm, which is the everolimus, assuming that there is no major issues with your clinical situation, then you will be allowed to receive this extra 2 treatments with PRRT. This is a collaboration between 2 different cooperative groups, SWOG and the Canadian cooperative group. So Dr. Chauhan and Dr. Singh are the lead folks for this trial. I think it's super exciting. And it's a 2-to-1 randomization, meaning that when they flip the coin, the computer chooses, there is a 2-to-1 chance that you're going to get the lutetium first, or 66% versus 33% chance. Another study that is actually in France is looking into, again, the retreatment with PRRT for patients with midgut tumors. So patients receive the usual 4 cycles of PRRT, and then if they have progression, they receive another 2 cycles. And then after that, there will be a flip of the coin, and the computer chooses whether you get another 2 cycles for a total of 4 versus you just monitor. And I think the main question to be answered here is like, there's 2 questions, right? Number 1, to see overall what's the retreatment benefit, and also, do we really need to go for an extra 4 treatments, or only doing 2 treatments is good enough? And that's debatable. If you look at folks in Europe, there's folks that feel very strongly that they should have a full round of 4 treatments. Some feel that just 2 treatments is enough and safe. And that's one of the reasons why the US study and Canadian study is looking at 2 treatments. But the French is looking at even all the way up to extra 4 treatments. Then another hot topic here is the use of retreatment with alpha emitter. And in this case, is actinium-225. And this called Action 1 trial. That's from the company that is sponsoring this is RISBio. This trial was presented at NANES at a symposium last year as a trial in progress, and you can see in the bottom here the information on clinicaltrials.gov. Patients that participate in this trial, initially was a phase 1 that has been completed, and we're waiting on the results of that. But once the trial reopens for enrollment, it's going to be as a phase 3 study, where patients are randomized, or again, the flip of the coin on the computer choosing if you get treatment with the actinium-225 alpha emitter radioisotope versus investigator's choice with everolimus, sunitinib, or either high dose of octreotide or high frequency of lanreotide, because we also know that both are very safe. In terms of eligibility criteria, you have to have a biopsy-proven, well-differentiated neuroendocrine tumor. The Ki-67 of your biopsies have to be equal or less than 20. So if you look at the pathology report, and the pathology report says that your Ki-67 is 25, unfortunately, you're not going to qualify for the trial. And unfortunately, there's no negotiation in terms of, can the company let me participate on the trial? These are very set rules that have to be followed in order to respect the trial, the FDA recommendations, and make sure that these studies are positive, that actually will translate to be available in a commercial way, right? To everybody. We'll make sure that it's available and approved by the FDA. Another thing that I have encountered that is eligibility barrier for patients is that patients that receive radioembolizations, right, radiation through that's used with liver-directed therapy, are not eligible. If you receive prior liver-directed therapy with chemoembolization or blend embolization, you are eligible for this trial. But if you receive radioembolization, such as Y90, you're not eligible for the trial. And I know that many patients have become disappointed that they cannot participate. But again, these decisions are made out of safety concerns, and we should respect the decisions of the investigators and sponsor of the trial. And in the back again, you have the clinicaltrials.gov identifier where you can learn more about the trial and see where this trial is open. So let's move to other clinical systemic options. I'm very excited and proud about this trial. This is an adjuvant study, meaning patients do not have disease. All the disease has been resected from the pancreas. And if a patient had up to 5 lesions in the liver, they were fully resected or ablated. So you have no active disease left. You are able to participate in the trial if you have grade 2 or grade 3 well-differentiated tumor. And why we're doing this trial? Because we know that some patients have very high risk features for recurrence. So even we resect them, we know that the tumors are going to come back, or there's a high chance, I shouldn't say we know for sure, there's a high chance. So this trial is looking into would giving chemotherapy after the surgery decrease the odds of the tumor come back in 3 years? And if the trial is positive, that would change how we manage the patients. Because right now, after the resection, we say, yeah, even though you potentially have a higher risk of the disease coming back, there is no therapy that we know that will make a difference. And we have these discussions all the time. And if the trial is positive, we will say, okay, maybe now we have something to offer for you. But if the trial is negative, we also will reinforce that really we shouldn't be giving treatment to patients because we're just giving toxicity without any benefit. So I feel very comfortable, granted I'm biased because I'm leading this study, that regardless of the results that we learn from this trial is going to be very important and impactful information one way or the other, because many folks give chemotherapy thinking they'll help, but we don't even know that actually works, and we might just be giving toxicity to the patients. Another trial, that's what's called registrational trial, meaning that if the results are positive, the FDA it will be looking to actually approve the drug to be commercialized in the US, is with cabozantinib, which is an oral pill, which is a TKI. And in this trial, patients with pancreatic NETs or extrapancreatic NETs, including GI or lung, are randomized to receive the drug versus a placebo pill. That's one of the few examples where placebo is used. But again, if you are randomized to receive the placebo pill, then when we see through scans that you have progression or that a patient has progression, they can be then switched to the cabozantinib arm, the drug, assuming that there is no issues with labs and your energy level and so forth. And this is also a 2-to-1 randomization, meaning the bigger odds that you're actually randomized for the active drug. Switching a little bit to paragangliomas and pheochromocytomas, which is a little bit of an orphan disease, I just want to give a shout out to Dr. Perez and Dr. Del Rivero, who developed this trial, again, thanks to the support of the NCI, to look into patients that have paragangliomas and pheochromocytomas that are locally advanced or non-resectable. At the time of progression, they can be randomized to receiving temozolomide and what's called PARP inhibitor that works with DNA repair damage, which is called olaparib, versus just temozolomide, which is a chemopill. Both are chemopills. And then we hope to see that perhaps using both drugs together, patients will have a longer progression-free survival, meaning, again, that they live longer without having the disease to grow or new disease to appear. Another trial, the drug was initially developed for a smaller population of patients with VHL, and now the drug is moving to look into studying this belzufitan, which is a hypoxia-inducer factor inhibitor, which is an oral pill again, in patients that have paragangliomas, pheochromocytomas, pancreatic neuroendocrine tumors, and any tumors that are associated with VHL, which is a syndrome that you were born as a germline mutation. And there are families that unfortunately have this mutation. And we know that patients that have this mutation that they were born with are high risk for developing RCCs, pheospars, and pancreatic neuroendocrine tumors. So another good option for what we could before consider a more orphan population. I just want to touch bases on switching gears to a little bit more of the aggressive tumors. We have this trial looking into chemotherapy plus or minus immunotherapy for patients that have neuroendocrine carcinomas, which are the poorly differentiated. Up to now, we know that we do chemotherapy as the first initial treatment for patients that are unresectable metastatic with a platinum, cisplatin, carboplatin, and toposide. But would adding immunotherapy be helpful? And this is because in lung cancer, we know that adding immunotherapy is helpful in small cell lung cancer. But we know that the genetic landscape of GI neuroendocrine carcinomas is a little bit different from the small cell lung cancer. So we actually need to test this in the GI aggressive population of neuroendocrine carcinomas. So this trial is doing exactly that. One good thing about this trial is that because we sometimes have to start treatment in patients that have diseases very quickly, because the disease can be quite aggressive, we can give the first chemotherapy cycle of the treatment and then enroll the patient on the study by the time that they are about to start the second cycle, as long as by the second cycle we know which randomization, which arm of the study the patient will get. So I highly encourage you all to have this in the back of your mind, particularly for those who might be dealing with a poorly differentiated aggressive neuroendocrine carcinoma. These are other studies that I'm not going to go into details, but I just want to give a shout out to some of these investigators. University of Washington is also looking on an oral pill to look at patients that have refractory and progressive well-differentiated neuroendocrine tumors in the GI tract, and looking to see if the pill is going to give any signal that works in delaying tumor growth. Another study is a phase 1/phase 2 study that is in develop in a Mayo Clinic, looking into this stomatitis viral expressing these characteristics here in patients with neuroendocrine carcinomas. This is for a patient population after they receive the initial treatment. And again, this is a devastating disease, so any trials are welcome to try to improve the outcomes of this patient population. And another study here is as a vaccine study that is developed at Roselle Park and is looking into patients with metastatic neuroendocrine tumors. And shout out here to the NERRF, or the Neuroendocrine Tumor Research Foundation, who is actually sponsoring and helping to make sure that the financial aspects of the trial are covered, because conducting clinical research can be expensive. So the donations that are done to the NRF make a difference, and kudos to them, in addition to many other sponsors such as the NCI that I mentioned before. And then, so what's my take-home message? So there's exciting progress in the neuroendocrine cancer field. As you can see, there are several clinical trials that are ongoing that might be a good fit for you. By no means I cover every single trial. There's so many trials from so many colleagues and folks that I don't actually know in person that I could not cover. So if I miss your trial, I'm asking for forgiveness. It's just that I couldn't cover everything in this short time that we had. But in the end of the day, just ask me or ask your care team about clinical trials, because there might be an option for you at some point of your cancer journey. And thank you so much for listening, and I look forward for the questions and answer sessions.
Welcome back, Dr. Soares. What an exciting overview of all the different clinical trials options that are out there. Thank you so much for this very educational presentation.
It was very rewarding to look into all these trials and exciting ideas that we have available now to help our patients. So thank you for the opportunity of sharing what I learned.
Yes. Well, we have several questions that have come in from the audience, so we'll go ahead and get started. I know that a lot of patients wonder, I mean, there's all these trials, wonderful trials that you've mentioned, and this person in particular said, I've heard people encourage patients to sign up for clinical trials, but when I talk to my doctor and I'm told that I'm not a candidate, so how or when am I a candidate for a trial, and what is the right trial for me?
Yeah, no, it's excellent. It's an excellent question, and it goes back to looking to the eligibility criteria of the trials, the inclusion criteria and the exclusion criteria, right? So your doctor and yourself have to make sure that there is that the trials that are available fit the timing of your treatment journey, and also that you haven't received possibly some therapies that might exclude you for the trial, or that your kidney function is good enough, or your blood work is good enough. Many trials, they say your hemoglobin has to be 9 or above 9. So if you have a baseline hemoglobin of 7, that doesn't make you eligible. So there's all these caveats that you can do the research yourself and say, okay, I want to do this trial, looking into the inclusion and exclusion criteria of the trial and see, oh yeah, you're right, because of this, I don't qualify, and now I understand my doctor. Or honestly, it doesn't hurt to say, doctor, I need to sit down with you and I need you to explain why I don't qualify for a trial. As you saw in the presentation, we have trials in different steps of a patient's journey, right? So we have trials even for patients that have just been recently diagnosed. We have trials for patients that need PRT, or that had already exhausted all the available standard of care options. And now we have a trial for us after a patient had the tumors removed for the pancreas. So it's really a question of sitting down with your care team and asking them to take the time and explain to you why such trial would or no not make sense for you.
Yeah, that's really helpful. I really like how you went through and explained the inclusion and exclusion criteria and showed us how to go about looking for that information. So along those lines, this person said, when searching the NIH site for trials, it seems the inclusion criteria are narrowed to a very specific type of NEC. Are there more comprehensive trials possible?
Yeah, so phase 1 trials that are all comers, meaning different histologies, they might be a good option, particularly if you have exhausted most of the standard of care options. And many of these phase 1s that, again, the main objective of a phase 1 trial is to look into the toxicity related to the drug or compound in question. But it might be an option for you, particularly if you don't fit the criteria for other trials, or you have already exhausted all the options. So phase 1 tends to have a little bit more of a generic inclusion criteria in terms of tumor types. And then most of the trials that are not phase 1 in the neuroendocrine cancer world, they tend to be either for GI NETs. Now we have the lung NETs. Some just say well-differentiated NETs. But yes, you are correct. Many try to focus in GI versus pancreas versus lung, and now with the paragangliomas and FEOs as well. So there might be a population of patients that we might not necessarily capture. But the cabozantinib trial or the cabinet trial is actually, as long as someone has a well-differentiated tumor, they just broke down in pancreatic and outside of the pancreas in a way. So that might be a possibility, again, depending on where you are in your journey and with your histological diagnosis.
Yeah, okay. Thank you for that. This is a very practical question. Is it solely the patient's responsibility to search and apply for clinical trials?
I don't believe so. I think it's a team effort, right? You don't, sometimes a clinical trial might not even cross your mind. So it's the job of your healthcare team to discuss that with you, or at least ask you if you are interested in clinical trials. I think sometimes physicians just, they process that information and they think that in their heads, and then they might not even mention to patients. And that might be something that if your physician doesn't necessarily do clinical trials, might be potentially less into their approach for you. But if you have someone in academic center, many times they will always be thinking about clinical trials. And I don't want to say that in a way that, doctors in the community do not think about clinical trials. They absolutely do. And I get tons of referrals from my colleagues in the community that they refer patients for clinical trials. I think perhaps if you're thinking about a first-line trial with somatostatin analog, that's potentially one time that I can see someone not being aware that now we have trials like the Cameras trials that is looking to the first-line use of the cameras for patients with neuroendocrine tumors. That's a situation that I can see a colleague not mentioning the trial. But again, this is teamwork. They should mention to you, and if don't mention, you should ask. And then in terms of searching, is again a collaboration, right? I typically tell my patients, okay, if I don't have the trial here, where do you have family, or where is easy for you to relocate while you are on trial? Because I cannot tell you, oh, just move to Manhattan, New York, if you're going to have to pay a hotel every night and you don't have the means. So it's also a little bit of a combination of make sure that you have a support system where you need to go for the trial if the trial is not in the place that you normally receive your care.
That's helpful. So it's a team effort. Yeah.
Absolutely.
Here's another practical question. Does health insurance cover the cost of clinical trials? What if the trial, as you mentioned, is out of state and your insurance, maybe they don't cover out of state care? What is the patient's responsibility?
Yeah, so this is a very complicated situation. So things that are routine or standard of care as part of the trial typically will be covered by insurance, and things that are done extra because of the trial, they will be paid by we call it sponsor or the trial. So if we are doing FDGs, the FDG PET, which is a PET to see the more aggressive nature of the cancer, if a trial requires FDG PET, most of the time we don't use that in patients with well-differentiated tumors, and therefore the insurance is going to say that they're not going to pay for that. And then we budget when we build the budget for the trial that this should be paid by the sponsor. So it's a little bit of a combination. Again, everything that's considered routine practice or standard of care, most of the time gets charged to your insurance. If there's something extra that's required specific for the trial, that's going to be paid by the trial. If your insurance does not cover outside of state options, might be extremely tricky if there are some components of the trial that are standard of care. If it's a phase 1 trial where everything is really considered research, then you should be fully covered. But to some extent, it's always important to make sure that you have basic coverage for IER visitor, for example. It's tricky. It's very challenging. I wish healthcare was easier.
Yeah, okay. So it depends on the trial, and there's a lot to discuss here.
And the insurance, it depends on the insurance, because, yeah, not having coverage outside of your state if you have to travel can be challenging.
Okay. Well, what's the patient's responsibility if it's in state? Does that affect it?
Goes back to anything that's a standard of care, that's routine practice. It might be charged to your insurance, and therefore you could be potentially responsible for co-payments.
Thank you. A follow-up question. Is it illegal for a trial coordinator to tell a charitable organization not to help a patient because the patient could get an FDA treatment instead?
No, I'm sure that the devil is in the details of how the situation happened. I will find this intriguing, to say the least. So perhaps, Lisa, maybe later offline we can try to get more details to see. I don't want to say bluntly yes or no without really understanding what is behind. But I don't even know how this will happen, to be honest with you. That sounds, it appears we're missing information here.
Yes. And perhaps this might be related to that question. Is there a nonprofit out there that might help cover the out-of-network costs and copays associated with a NET diagnosis?
Yeah, there are several organizations and foundations that help patients to get coverage for treatment. So work with your social worker and see which options are available to you. And then if they don't give you any help locally, I would encourage you to reach out to one of the wonderful neuroendocrine cancer organizations that we have, the patient organizations, and they might be able to help you. LACNETS is one of them, NCAN, HealingNet. They all have helplines that can help you navigate any of these challenges. Is that true, Lisa?
Yes, yes. We definitely have resources on
Yes.
our resources page for finances. Thank you for that. Let's talk about what happens during the trial. What happens when there are symptoms or side effects during the trial? Who manages it and how? And who needs to know? When would the symptoms be bad enough to stop?
Great question. So side effects and symptoms might happen on the trial. That's not unusual. And then your care team, particularly the doctor that's evaluating you while you are on trial, so the doctor that gives you the consent for the trial should be the one knowing, and the research team that works with this doctor. So typically in our case here at Huntsman, you have a research coordinator or a research nurse that you will have the phone number and access all the time. And then typically you will let this research coordinator or research nurse know. They will then reach out to me and say, this is what's going on. What should be the next steps? Is this related to the drug that we are that's on the trial, or this is not? What do you think? And then there is layers and levels of toxicity. And if a toxicity is bad enough, we sometimes have to hold the drug, and then when we restart it, we have to do a dose adjustment, meaning decrease the amount of the drug. And sometimes we do have to stop the drug. I just recently had a patient that was on a study, and she had a really bad allergic reaction. And we decided that it was no longer safe for her to be on the trial. The trial is doing well, continues to go on. Don't worry about the drug in question. I'm just sharing this because, yes, sometimes we do what's the safest thing for the patient, first of all. And if we don't think that is safe, we will stop it. And all these trials, they have very well established toxicities that are expected and what to do in terms of which toxicity, Mild nausea is very different from someone that is throwing up every hour because of how much GI toxicity they had, right? So we follow very well-established recommendations to treat patients.
Wonderful. That's really helpful. There was this question that was submitted. Can a physician stop a patient? You talked about stopping a trial. Can a physician stop a patient from participating in a trial without the patient's knowledge or for no reason?
No, I would say yes, a physician can stop a patient participation on a trial. And typically this happens for safety concerns or disease progression, or perhaps the patient wasn't following the instructions and the physician felt that was no longer safe for the patient to be on the trial. But he can absolutely not do that without letting the patient know. So they might have, if this happens to someone, might be a miscommunication. And normally there is a reason. Perhaps it just hasn't been communicated well enough to the patient. So no, we couldn't just stop for no reason. And there's steps for that.
Thank
but
you.
we can stop it.
You can stop it. Actually, there's this question as well. What are the reasons to stop a trial? I know you were already touching on it,
Yeah.
and then who can decide to stop?
Yeah, just to retouch. So if the patient has disease progression on the trial, meaning the drug is clearly not working, we're not going to continue, with very few exceptions typically related to immunotherapy, that sometimes we can do treatments beyond progression for a limited amount of time. But disease progression, tumors growing will be one. Side effects, they are too hard on the patient, and we already did all the dose reductions. We try as much as we could to adjust the doses, and the patient is still continuing to have side effects. We'll stop that. Any anaphylactic reaction, we're going to stop. If we think that the patient is non-compliant for whatever reason or can't follow the instructions, we will also stop, right? If for example, we tell you, the drug should be taken once a day and for, I'm making this up, 2 weeks. And then the patient say, no, I just want to take the drug once a week. Then this patient is not someone that is willing to follow the instructions, and then we'll take them out of the trial. But most of the time, patients come off trial either from toxicity or disease progression.
And actually, that's a good segue to this question. What happens when there's disease growth or progression when on the trial? I guess specifically, what is crossover? Can you explain that a little bit?
Yeah, so crossover is that so if the patient is on a trial that there's just one option, right? There's only one arm, then there's no crossover. But if there are trials that you can be randomized, right? The flip of the coin between drug A versus drug B. And let's say everybody wants to be, all patients feel that they should be on arm A. but they got randomized to arm to the B. At the time of progression, if the patients are still doing well, the blood work is still okay, and they want to continue the trial, these patients are given the opportunity to then finally receive the drug A that is felt to potentially be most beneficial. So we have few examples of that. The cabinet trial where patients receive cabozantinib or placebo. At the time of progression, if they receive placebo, they can be randomized to, they can be then given the opportunity to receive the cabozantinib. The acting one trial with the alpha emitter, the same thing. If they were randomized to receiving standard of care at the time of progression, then they can receive the alpha emitter with actinium 225. So crossover is allowing you to receive the other treatment.
Ah, that's really helpful. So you mentioned the cabinet trial, and one person asked, what is the status of the cabinet trial?
Yeah, so is it still open? Is it still enrolling? If any of you had discussed this trial with your care team, please consider if your care team feels is a good option for you. I think it's more than probably 60 to 7% enrollment right now. And we really need everybody's help to complete this study because, again, I'm really looking forward to the results. And if they're positive, that is going to lead to another, hopefully the idea is that this is going to lead to the approval of this drug by the FDA, and we'll be able to provide this drug in a standard of care fashion. So yeah, it's moving along, and I'm really hopeful that we can get to the number of patients needed in the next year, so we can see if that's another drug on your toolbox for our patients.
Yeah, thank you for emphasizing again how important it is to engage in the trials and participate so we can get more tools in the toolbox, more drugs.
Yeah, that's one of is the giving part of being part of a clinical trial, right? It can be helpful, it can be beneficial to you, but you are actually part of changing history of a disease and helping many folks that come after you, so they don't have to face the same thing that you went through. So that's the giving part of participating on a clinical trial, but it's a legacy, right? We always think about which legacy we want to leave behind, and I feel that being part of a clinical trial is part of a beautiful legacy that a human being can leave behind.
Yeah, I know that's really meaningful to you, and I can tell by the emotion that you put into it. Yeah, yeah. You also mentioned the alpha trial. Of course, there's a lot of questions about this, and basically, what is the status of the current alpha, the lead and actinium PRT trials, and are the results of the phase 1 lead trials at Excel Diagnostics available?
Yeah. So the action one was the actinium trial that's for retreatment. They enrolled in the phase 1 portion of the trial that was completed, and they paused. And now we are all happy to report that it's going to be reopened, and we believe in April 15, patients will be able to discuss again this trial, receive consent, and hopefully enroll on the trial. There are several centers in the United States that have this trial. If you go to the clinicaltrials.gov, you can see the list of all the sites that are enrolling. In the West Mountain, we do have the trial here at Huntsman. I think in Florida, Moffitt has the trial, and I'm sure, Lisa, you can share later the other places that have the trial as well. So April 15 is when we're hoping to start enrolling patients in the phase 3 portion now. And then for the lead trials from the Excel Diagnostics, they are enrolling in the naive patients and still enrolling on the retreatment portion as well. I believe in addition to Houston, at least Moffitt has the trial, and if you contact Excel Diagnosis, they might be able to let you know of all the sites that have that option. And then you can contact the sites that's probably closer to you.
Yeah. Actually, can you talk about that a little bit? You talked about many sites. How do people know what sites, and are they all open at once, or do they kind of have a rolling opening and closing? How does that work?
So a little bit of both. So to know about all the sites, either you have to go to the sponsor websites to know, or go to the clinicaltrials.gov. The sponsors, meaning who is supporting the trial, really tries to keep that up to date. So if you go to the Action 1 trial with the Resvio, the Actinium-225, you can see listed all the sites, meaning all the cancer centers that have the trial open. And typically, for each cancer center, there's a contact person with the email from the contact person. And is not every single trial will be open in every single site at once. It takes a little bit of time to get the trials through the regulatory process of getting the trials active in a particular site. So, for example, the Compose trial is opening several sites, and we are in the process of opening a Huntsman. So we don't have it right at the second, but hopefully in a few months from now, we will have that open and ready to enroll patients here. So just keep track on the clinicaltrials.gov, and you'll be able to see the sites that already have the trial. Also, I should mention that Josh Mayman, he was working with company to develop a patient-friendly way to find trials. I believe the name of the platform is Ancori, and I think you can find that online as Ancori at ai.neuroendocrine. And that's another way that you can potentially look for trials that is, I think, very patient-friendly to search for.
Yeah.
And Lisa, again, later on, feel free to share the information in more detail. Oh, you have it there.
I'll put it up there. So
Yeah.
you were mentioning about opening trials at different sites. How do people know if their spots open? I mean, if the sites are open for the trial, does that mean there will be spots?
No, so sometimes there's not a spot right at that time, especially for a phase 1 trial that you need to assess the safety. So, and many times, you treat 3 patients, you wait for them for a period of time, which is called DLT, dose limiting toxicity timing, to make sure that there is no side effects that are serious, and then you can put more patients. So that means that sometimes we don't have a slot for a patient. But for the phase 2s and phase 3s, as long as one qualify, they should be able to enroll on the trial. It's really contacting that person on the email for the site and say, hey, I'm interested on this trial. Do you have slots? When would you have slots? And they should be able to navigate you through that, and your physician as well.
Great, thank you. There are several questions, Dr. Suarez, about if there's trials for this specific thing or this specific thing, lung nets or peritoneal disease. So here's one example. Any clinical trials for treatment of peritoneal seeds of nets?
Not in the bigger sense of big phase 3 trials. There might be some institutions that are very big into HIPAC, for example, because that takes care of that. They might be looking into that. There are smaller trials, but not in a bigger national sense that I'm aware of. So no, and if someone knows, shoot us an email and then we can spread the word. But I think this is more if there's something just from one particular institution.
Okay. And then this is probably a common situation. Are there trials available for patients who have extensive hepatic or liver metastasis with no chance for surgery?
Yes, if the patients have adequate liver function, then they should be able to qualify for many of the trials that I mentioned. And the key is on the eligibility criteria, right? As long as your liver function is up to 3 to 5 times within the upper limit of normal on the labs that we look, you should be able to qualify for a trial. However, if you have significant liver dysfunction and your liver enzymes are very altered because of the disease, then probably you're not a candidate for a trial.
Okay. And similarly, are there current or proposed trials for mid-gut NETs with systemic disease who are not surgical candidates?
Yes, so the PRRT retreatment trial from the NCI with Dr. Simron Singh and Dr. Aman Chauhan is a trial for mid-gut tumors. Many of the other trials, the RESBIO trial also treat patients with mid-gut tumors. So the vast majority of the trials are including mid-gut, with the exception, one exception that I can think right on the top of my head or two are the lung net trials, such as the one from Dr. Hope, and the Alliance trial that Dr. Hobney is leading, that I also support because it's a trial specific for pancreatic neuroendocrine tumors. But other than that, most of them should include mid-gut tumors.
Okay. What about lung net who don't have any receptors?
Yes, so they could be eligible for the cabinet trial. That's one option. There's other options in terms of drugs that are being developed, but if they don't have receptors, they're not going to be candidates for PRRT type of trials, unfortunately, because we know the patients need to have the receptors for the PRRT to actually work. But any other systemic treatments, they could be potentially eligible, such as the cabinet.
Are there any clinical trials that work that target the MEN1 mutation?
Not that I am aware. Again, there is when you put on clinicaltrials.gov, you get like more than 1,000 hits. I am personally not aware of any trials that is specific for MEN1 mutation patients. If someone knows, please share with us, and we will spread the word around.
Okay. What about unknown primary net with liver metastasis? Do you qualify for clinical trials with unknown primary?
You should. I mean, especially some of the examples of trials that I share, you could see that if you believe the unknown is most likely from GI origin, they should be okay to be enrolled in a trial. And sometimes even the languages of just unknown is really mentioned in the eligibility criteria. So it shouldn't necessarily stop you from participating on a trial. And most of the time, when it's unknown, you can also many times you can make the case that it's actually from GI organ, because it takes a very little small bowel tumor to do a lot of damage outside of the small bowel.
Thank you. Just a couple more questions. What about immunotherapy for NET? For example, CAR T cell therapy.
Yeah, there are. We don't use a lot of immunotherapy as a standard of care for well-differentiated NETs, because all the trials that have been done so far has been mainly negative. There are few trials trying to enhance or boost immunotherapy, either using the traditional immunotherapy agents with something else, such as PRRT. CAR T cell. I think is still in development. Actually, Dr. Strasberg from Moffitt and Dr. Mauro Civis in Italy are working on strategies for that. But right now, I cannot think of any specific ready to rock and roll enroll patients that are specific for NETs and in CAR T cells. But there's certainly a lot of research on that. So soon.
Stay tuned soon.
Yes.
Okay. Well, in closing, I'm wondering what closing thoughts or word of hope you would like to leave the NET community with. I know this is an area of passion for you, and we're really grateful. And because it's personal, especially, what would you like to share with the community?
Yeah. So I show you some of the pipeline and how much it took before to develop new treatments, and you saw, how many trials we covered today. So there's so many folks working in trying to improve the care of NET patients, and it will continue to move on. I think many doctors in the community are becoming more aware of the importance of improving the care of NET patients. And I tell many of my patients, the name of the game is to keep you alive and healthy until the next best option comes around. And that will only happen with trials and with participation of the trials. And again, they are only possible if patients are willing to donate their time, their courage, and their trust to the care team, and we'll get there. Yes. The name of the game is keeping us healthy and around until the next best thing comes around.
Yeah. And we're all in it together.
Yes.
Yeah. Thank you so
Absolutely.
much for all you do for this, for leading the trials, developing, advocating for it. We're really grateful for you, for not just all the information and education, but especially your heart around this. Your passion is
Oh, thank you.
palpable.
Thank you, Lisa.
Yeah,
Yeah,
thank
and
you.
my pleasure to be part of the LACNETS webinar. You know, I always tell them I get so nervous when I join, but it's always fun, and I
Yes.
enjoy it. Thank you, and thank you for you to listen, and hopefully that takes away some of the mystery of clinical trials.
Yeah, we hope so. We hope to demystify it. And thank you again. And we look forward to next time we can talk. So
Thank you.
now I'm going to hand it back to Heather in the studio.
Thank you, Dr. Soares, for that informative presentation and addressing those important questions from our live audience. Educational programs like these are made possible by our sponsors, Ipsen, Advanced Accelerator Applications, ITM Pharmaceuticals, Lantheus, and Crinetics, and donors like you. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high quality broadcast production. Follow us on social media to stay up to date on our net news. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. We want you to know that you are not alone. LACNETS is a community of support and resources, and we offer many programs, including our weekly virtual NET support group, our monthly caregiver-only support group, NET Vitals, which is our NET communication tool, and a health and wellness coaching program. We are proud to share that NET Vitals was featured in the medical journal Pancreas last year, and it was also published recently in the Journal of Clinical Medicine. We encourage you to go to our website, lacnets.org, to find out more information and find resources. LACNETS also has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the transcript, resources, and the 10 questions we ask each expert. Goodbye, and we hope to see you on April 14th for our next webinar.